welcome everyone. A few housekeeping items before we begin. This session is being recorded. It will be available on our website in a few days. That is concussion.umich.edu. There will be some time for discussion at the end of the presentation, but feel free to enter questions or comments in the chat. This session has been approved for CME and Board of Certification Category A credit. You'll receive an email after the session with information you'll need to claim the credit. The session is also approved for American Psychological Association CE 1.0 credits, and the athletic trainers are approved for credit with the completion of the evaluation. If you registered with your BOC number, you'll be able to receive the evaluation following the speaker series. Give that a test.
Good.
And we'll proceed. Everybody, glad you're here today. Thank you for joining. Welcome to the University of Michigan Concussion Center. My name is Doug Wiebe, and I'm super excited that you're able to join us and spend some time at our speaker seminar today. Over the years, I've been fortunate to know and work with some of the world's leading researchers and clinicians. The goal of the speaker series is to bring those speakers to you and create a space where you can hear and learn from those who are challenging what we know about concussion and create and implement new knowledge in your daily lives. I'd like to give a warm welcome and a special thanks to our speaker today, who I'm extremely happy to introduce. Dr. Carrie Esopenko is an associate professor in the Department of Rehabilitation and Human Performance at the Icahn School of Medicine at Mount Sinai in New York. Also, she's an adjunct associate professor at the Traumatic Brain Injury and Concussion Center in the Department of Neurology at the University of Utah. The topic today, understanding the intersection between brain injury and PTSD. Dr. Esopenko will discuss how mild traumatic brain injury impacts military service members returning from deployment, the current research surrounding intra-partner violence and military sexual trauma, and the intersectionalities between these head injuries and post-traumatic stress disorder. We look forward to hearing from you. Thanks for coming, Carrie.
Thank you. Thank you so much for the invitation to be here, and also for allowing it to be 70-degree weather in Michigan in October. Very grateful for that. Yeah, so today I'm going to talk to you about some work we've been doing and others have been doing on the intersection between brain injury and PTSD. These are my disclosures. They don't impact anything we're talking about today. I do want to give a content warning. We will be talking about interpersonal violence, and I recognize that this content may be triggering for some, so feel free to mute me, leave, whatever you need. If you need to chat after this presentation, feel free to reach out. So we're going to start and talk about TBI and PTSD in military personnel and some work that we've been doing. So we know that approximately 10 to 20% of military personnel returning from combat report TBI or probable TBI, and around 80% of those injuries are classified in the mild traumatic brain injury area. And mild traumatic brain injury in military personnel can result in cognitive symptoms such as slower processing speed, impaired executive function, attention, and concentration. We see neurobehavioral and psychological symptoms such as headaches, sleep disturbances, depression, anxiety. On a positive note, we do see many of these individuals are recovering, but there is this, significant proportion that do experience chronic cognitive and mental health complaints. And, one of the things we ask, is it because of psychological comorbidities? And so many military service members who are clinically diagnosed with mild traumatic brain injury also experience psychological comorbidities such as PTSD. It's been estimated that around 10 to 25% of military personnel experience PTSD and PTSD symptomatology. And one early study by Hodge and colleagues demonstrated that around 44% of soldiers who had a loss of consciousness, 27% of them reported PTSD symptoms. And, TBI and comorbid PTSD have a really complex set of symptoms and features that significantly overlap and really impact treatment abilities. So, we see symptoms that are because of what we would call it from TBI. We see symptoms that we would think are from PTSD. And we have this cluster of overlapping symptoms in the middle that are happening in both PTSD and TBI. And so all of these together and then trying to figure out where they come from is very difficult, and it makes treatment and management difficult. So we've been trying to ask this question in the lab, and that is, in service members and veterans who have experienced TBI, is there specific psychological and cognitive symptom clusters symptoms that cluster individuals into subgroups and reflect diagnostic classification? So basically what we've been thinking is, we have been clustering people in, you've had a TBI, you have PTSD, you have both, you should be like A, B, and C. But we've been saying, well, what happens if you remove those labels? What happens if you start looking at people's symptoms specifically and not the diagnostic classification? So we set out to explore this, and I have to give a big shout out to Nikki D'Souza, who was my PhD student at Rutgers and is now doing a postdoc at Mount Sinai with Kristen Doms-O'Connor, as well as David Tate and Lisa Wild from University of Utah, who provided us with this data. But basically what we started doing is looking at active duty service members who had a history of TBI, current PTSD, or comorbid mild TBI and PTSD, and then orthopedic controls. All of the individuals in this sample were receiving cognitive rehabilitation. They had all completed a very comprehensive neuropsychological test battery that assessed cognitive and psychological functioning. And so what we did is we did a latent profile to determine how neuropsychological outcomes clustered together. And so basically with LPA modeling, it's an approach that can identify latent subpopulations within a sample based on the variables that are included in the analysis. So it's kind of like throwing everybody into the pot, circling, and then seeing how they fall together is the easiest way to sort of describe it. And I know the modelers are like, no, but that's, kind of how it works. So we basically took the diagnostic classifications from each person off, right? And then we put the symptoms into the model, and we looked at how they separated. So when we looked at the symptoms, you can see the psychological indicators and cognitive indicators. So the psychological were all the self-report, cognitive indicators were all the objective neuropsych. And then we looked at how they felt. So I think colors came across good. New screens, glorious. But the green you can see is high functioning. Then we have the blue group we're calling normal functioning. So in the high and normal, they are high is good across the board, by the way. So everything has been inverted. So high is good, even it's not high symptoms, it's like good on the symptom scale. But the blue and the greens are showing good on the symptom scales and doing pretty well cognitively. Then you see this sort of middle group that's black. They're showing no symptoms, but they're showing sort of declines in cognitive functioning. And then we have the orange group, which is like tons of symptoms, doing okay cognitively. And then the red group that's showing not doing well, right? So they have lots of symptoms and cognitively not doing well. By not doing well, they're doing lower than the mean. Sorry, they're doing okay. I should revamp how I said that. So this is how it ended up falling when we look at this. So we had in the high functioning group, it's just another way of looking at this, that you can see for high functioning, everything's looking good. Normal functioning, it's all, again, pretty much looking well, then cognitive symptoms, and then the combined. Then what we did is we did a Saki plot, which our biostats guy calls this the Harry Potter's sorting hat, which I love. So basically we then relabeled the individuals, right? And so then we looked at how the individuals, once they're relabeled as control, mild TBI and PTSD, and how they fell within those categories. If you look over at the comorbid mild TBI and PTSD, you can see that they fell into very different categories, right? So the blue is that normal functioning, very small percentage of them fell into that normal performance category, but the rest of them were falling into having some sort of situation happening, whether it's the mixed cognitive or combined cognitive and psych symptoms, or if it's cognitive and psych. And then the TBI and PTSD fell how we would pretty much expect it, right? PTSD was mostly in the symptoms. And then for the mTBI, most of them were looking good, but there was that 30% that was still showing cognitive symptoms. So then what we wanted to do was expand this and see how it worked when we looked at a giant sample of individuals. So we then took data from the LIMBIC-CENC data set, which is a DoD and VA research study that focuses on the long-term effects of cognitive or combat-related and military-relevant mild traumatic brain injury. So again, big shout out to Nikki, who was really running all of these analyses, and Hannah Lindsay for curating the data so that we could do this. But we ended up with a sample of almost 1,700 military service members and veterans. They completed a pretty similar battery that we had in the I-score data, but a lot more. And we also had different groups here. So we had a group that were unexposed. We'll say they didn't have a head injury or a TBI or combat TBI or non-combat related TBI. And sorry, this is stuck. There we go. Okay, so then we did the exact same thing. So we ran the latent profile, but you can see here, now we've like doubled the number of tests that we're using to see how if it's more sensitive in identifying these different groups. And as you can see, we have more functional levels happening here. So we have, again, everything high is good, right? So high symptoms is actually good. The blues, they're all in that higher functioning for symptoms. And then you can see the dark blue across the top is like high functioning for the self-report, and then high functioning in the cognitive performance. And then it goes down from there to the dark, I think that's like a red, the dark red, which is lots of symptoms and also doing not as well cognitively. Okay, so it sort of falls out the same way, but more sensitive to different levels of performance. When we look at this, again, similarly with the test types and how they fall, again, you can see how it breaks out where you have the high self-reported functioning and high cognitive all the way down to the low. So everything sort of on each end falls together. So then we went and did Harry Potter's sorting hat. It's never going to get old. So when we looked at this, so now we've put the labels back on, right? And so you can see at the top, we have our unexposed individuals. And at the bottom, we have people that have both combat and non-combat TBI. So it's almost like an exposure variant, right? You're going from like none to more. In a sense, you can look at it that way. Then when you look at the plots over here, you can see that the unexposed group, for the most part, those individuals are falling in those higher or middle level functioning. But when you look over at the more exposure, you're seeing darker reds, right? So what it really ends up looking like is that the unexposed who had non-combat TBI were more assigned to these these higher functioning groups. And then when you look at the more exposure that you see, they're falling more so in that lower functioning exposure group. But then the question is, what happens when we add PTSD in, right? So when we look at that intersection between the two of them. So to break this down, it's set up the same way with the colors mapping onto the groups, like the functional groups, except for now you have blocks horizontally, which are either no PTSD or PTSD. So the unexposed is still over on that side. The more exposure with the combat plus group over here on this side, on your right is the PTSD component. So here now, when you look at this, the unexposed is still on that other side, looking a lot better in the higher functioning. So they're over here, we have that more higher functioning group are the people with, no PTSD and lower exposure with brain injury. On this side, once you see more PTSD and more exposure with brain injury, we're seeing them falling more in that lower functioning groups. So together, these results are demonstrating that, neuropsychological and self-report measures can really help us differentiate functional profiles and maybe better able to identify distinct groups and allow us maybe to help develop better profiles to then treat individuals. And so instead of just classifying that you have PTSD or you have TBI or you have both, you should get this. This will help us classify better. And so why is it so important to consider this? So why is it so important to understand and consider this overlap between PTSD and TBI? Well, having PTSD can result in the TBI symptoms being worse and more complex to treat, making it difficult to treat. While on the other side of it, the TBI actually reduces the effectiveness of the PTSD treatments. And so it's like this chicken and the egg, that if we're not identifying sort of where those symptoms are coming from, it's making it harder to offer an effective treatment. And one of the things that we think really underlies this is problems with emotional dysregulation. So both TBI and PTSD have a shared neurocircuitries, shared clinical presentation, and shared behaviors of emotion dysregulation. And they think that it's tied to changes in neurocircuitry, changes in HPA activity, excess glutamate in the brain, disruptions in the prefrontal cortex, amygdala, hippocampus, and the neuroreceptors in there, as well as transcription factors for gene expression. There's also overlapping impairments in frontal limbic connectivity, which are resulting in this, as well as disrupted functional coupling between the prefrontal cortex and insula. And if anybody is interested in this paper is incredible. I highly recommend taking a look at this. But it seems to be this overlap of emotion dysregulation that results from both of these that is impacting the treatment. And what this does, for example, with TBI, because it can result in emotion dysregulation, this impacts the individual's ability to complete gold standard treatments for PTSD, like prolonged exposure therapy, because you don't have the emotion regulation to be able to complete those, so then it's not working. And this is, I have to do a shout out to Delene Menifee and Maria Kajankova. We're doing some work on this right now and hoping to do some intervention work with this. So when we talk about brain injury, we often think about this. And lately, for the past almost decade now, I guess, we've been, thankfully also talking about women and what's happening in female athletes. And shout out to Ali Krieger, who's retiring at the end of the season and just helped get Gotham through to the semifinals for the NWSL next weekend. Can't wait. And when we hear about brain injury and PTSD, we often think about this. Did you find the duck, Landon? But what we also need to be thinking about is brain injury and PTSD symptoms in those who experience interpersonal violence. So again, content warning. So intimate partner violence, what is it? Well, it's a behavior by an intimate partner or dating partner that causes psychological, sexual, or physical harm, which can include physical aggression, sexual coercion, psychological abuse, or controlling behaviors. I just realized that I still have this written in Canadian. And approximately 1 in 3 women worldwide will experience intimate partner, physical or sexual intimate partner violence over the course of their lifetime. And some stats on this. So according to the CDC, approximately 33% of women report physical aggression, severe physical aggression from an intimate partner in their lifetime. And both men and women do experience IPV. However, violence against women tends to be more severe and result in more chronic and severe injuries and long-term outcomes. And we know that more than 80% of Indigenous women in the United States experience IPV, stalking, or sexual violence, with approximately 55% experiencing physical intimate partner violence in their lifetime. We also know that sexual and gender minorities face higher rates of IPV in comparison to cisgender and heterosexual peers. And women of color and women with disabilities also experience higher rates of IPV. So just how many people in here like work with college athletes? Yeah, figured with this group. So many of you are like frontline with our college athletes, right? With people that are 18 to 24 years of age. Well, they are actually at the highest risk of IPV. So you may be the front line of defense. You may be the first person to notice. So I'm here to empower you to know about this, to realize that it can be happening and to be aware, but also to empower you that being aware and being able to provide support is needed. So if you are noticing that you need to understand how to refer out to resources for individuals, but it's mostly prevalent in our 18 to 24-year-olds. Military sexual trauma, on the other hand, is sexual harassment or non-partnered sexual violence that has occurred during military service. So this can be anything from catcalls to military sexual assault. And our veteran affair data shows that 1 in 3 female vets report exposure to military sexual trauma. And female vets are also 1.6 times more likely to experience IPV than civilians. And when MST does occur during service, female veterans are shown to be at a heightened risk for future IPV. So it's like the cycle, right? And it happens and then it keeps happening, or it puts people at more risk. And so since physical and sexual IPV, and we expect, and we're really trying to look at this, military sexual trauma includes injuries to the head, face, or neck, as well as strangulation, suffocation, and other forms of impeded breathing, there is a high risk of experiencing brain injury in this population. So there's been some systematic reviews that have looked at this and have shown that, you know, anywhere between 19 to 100% of women who are in studies looking at IPV brain injury report experiencing IPV head trauma and facial trauma. And just like a caveat of the 100% is like the studies are recruiting for people that have experienced this, which, you know, then puts it at 100%. However, it's thought that up to 92% of women who are exposed to IPV experience probable brain injury. And what we've also seen is that approximately 50% of women in these studies report multiple exposures to head injury or brain injury in these relationships. And others come back and report too many injuries to even be able to count. So they'll say, some will be like, I've had like 200-300, and it's like not actually an overestimation. Like they feel like they've experienced so many of these situations and these injuries. And there has been some people trying to predict epi on this, and they estimate that approximately 23 million women are living with IPV-related head trauma in the United States, yet it's often ignored and not examined. And so hopefully what we're empowering everybody to start, you know, asking the questions about IPV brain injury and whether people have been exposed to violence-related head trauma. So when we think about IPV and potentially MST, these injuries likely represent a distinct brain injury population given the different mechanisms of injury. So, for example, individuals who experience IPV can be kicked, punched, hit. This can lead to focal neural trauma, focal injury to the brain. Also be shaken violently, pushed, shoved. And this can result in diffuse injury. And of course, there's also overlap in the injury to the brain that's happening for all of these. Then we have non-fatal strangulation, suffocation, or other forms of impeded breathing. And this can result in hypoxic ischemic injury. And this is, you know, important consideration for brain injury is, you know, studies have shown that attempted non-fatal strangulation has been reported in up to 68% of women in abusive relationships. So this isn't a very important consideration, and it's often not thought of as a form of brain injury, but it's one that we really do need to be aware of and start investigating more thoroughly. The other thing that really sets this apart, though, is that many times within a single abusive episode, all of these can happen at the same time. So the individual can have experienced every single one of these, resulting in a myriad of trauma and injury to the brain. And the other thing that's even more problematic here, I don't know how we keep saying more problematic, extremely problematic here, is that these injuries are often extremely repetitive, right? So we have the people saying that they have experienced this way too many times to even count. So you have repetitive exposure to this, potentially within a single episode, or in many episodes over many years, right? So it's building up. And when we look at IPV, so just exposure to IPV, even in the absence of head trauma, we see alterations or cognitive alterations. So we see impaired reaction time, response inhibition, working memory and executive dysfunction. We see cognitive or psychological and psychosocial problems, things like depression, anxiety, substance use disorders, suicidal ideation, and PTSD. We also see neurological changes, so reduced cortical thickness, white matter integrity, and alterations in functional connectivity. And so early studies from Kathy Monahan and Eve Valera really sounded the alarms. So in early 2000s, 1999, early 2000s, they sounded the first alarms that, you know, women who had experienced partner abuse are reporting exposure to head trauma. Then there was a gap in time, unfortunately, of studying it, but then we started seeing data coming out from clinics where the Barrow Clinic with Glennis Lehman's group that showed in individuals coming in for brain injury, treatment for brain injury, that there's a lot reporting injury due to domestic violence, and that these injuries were associated with cognitive, psychological, and behavioral symptoms. Then we started seeing data coming out showing that there's really high rates of PTSD in brain and partner-inflicted brain injury in civilians and veterans, and that the exposure to partner-inflicted brain injury was resulting in worse and more severe PTSD. And then we started seeing lots of symptoms in, we started seeing cognitive and motor, studies showing cognitive motor function issues with more severe forms of IPV brain injury. And then recently, Eve Valera published a paper showing strangulation-related brain injury specifically was associated with worse cognitive and psychological functioning compared to individuals who had experienced a non-strangulation related partner-inflicted brain injury. There's only been a few or handful of neuroimaging studies, but they've shown, so Eve Valera developed a screening tool and developed a brain injury screening assessment, the BISA, where you can develop a brain injury score, which accounts for the recency and severity of the injury that the person, or of the number of injuries that the person reported. And what she found was that greater severity of brain injury was associated with reduced functional connectivity from the insula to the posterior cingulate. Looking at white matter, she also found that increased brain injury severity was associated with decreased white matter integrity in the posterior corona radiata and superior corona, corona radiata. Then there's been other work that has recently come out that has shown that in women who report IPV brain injury, they show reductions in cortical thickness within the superior frontal gyri and the precentral gyri, as well as when they looked specifically within the group that reported IPV related brain injury, they looked at IPV related brain injury compared to other forms of or non-violent related brain injury. And they found that there were reductions in cortical thickness in the right paracentral gyrus. And so these are still very small samples. And so we need to like expand the imaging on this, but what we're already starting to see is that there is this association between exposure to IPV brain injury and changes in brain function structure or white matter and cortical thickness. But we've been trying to look at what's happening in military sexual trauma specifically. And big shout out to Delene Menifee, who's the Women's Health Program Manager at the Houston VA, who has been running a intervention, or ran an intervention for women who had PTSD and had experienced interpersonal violence. And the majority of the people I'm going to talk about in this sample had all experienced MST, or for the most part. And so what we were able to do with this sample is look at the co-occurrence of MST, IPV, and their cumulative impact. So what happens when they start building up on psychological symptoms. And so we had a sample of 300 vets who were enrolled in this inpatient trauma-focused treatment program. And then we looked at PTSD, depression, and current suicidal ideation. And overwhelmingly, so the light color there is both MST and IPV. And over half of our sample reported exposure to both. So they had been experienced MST and IPV. The darkest up in the corner, the 10%, is the smallest group that had no exposure to adult interpersonal trauma, which means either MST or IPV. So the majority of this sample is reporting cumulative trauma, right? Cumulative exposure to interpersonal trauma. And then when we look at PTSD, we see that our female vets with MST and IPV showed way higher scores on the post-traumatic stress scale, as well as on depression. And that those with the cumulative trauma or exposure to both are the ones that are doing worse. And we're looking at the outcomes from the treatment right now, so stay tuned. I'll hopefully be able to report those to you shortly. But because we're trying to look to see how that cumulative exposure actually impacts our ability to treat PTSD in this sample. And what we found, though, is that in this approximately, so the clinic didn't ask specifically about brain injury because they weren't aware that that was such a big issue at that time. It was like 2009, I think, when this started. But what they did see is that the individuals in the MST and IPV group had also had the highest rates of childhood physical abuse. So they had experienced physical as well as sexual abuse. So not only are they in adulthood reporting exposure to cumulative trauma, but it started young. So they've experienced this accumulation of trauma over the course of their life. And it resulted in around 54% of this sample reported previously attempting suicide, and more than 30% reported trying more than once, right? So the cumulative exposure to trauma resulted in worse PTSD, depression, as well as higher suicidal ideation. We also are looking at this military sexual assault specifically, so the most severe form of military sexual trauma. And military, we could characterize this in both male and female veterans. And what we did is had veterans complete surveys that explicitly asked about the assault, what happened, or how they felt within the first 24 hours, and then 1 week after, and then as well as measures of PTSD symptomatology. All of the participants obviously had experienced military sexual assault, but almost half of them reported experiencing more than one. So they had experienced multiple assaults in their during their military service. And within that sample, 23% reported being physically beaten, 18% reported being strangled or suffocated, and 9% reported being knocked unconscious. And almost 90% of that sample met the criteria for PTSD. So again, we're seeing this overlap between pretty high rates of exposure to physical trauma and likely conferring high risk for brain injury and high rates of PTSD. We also need to focus in on, as I said in the intro, that IPV in our transgender and gender diverse individuals is extremely high. And in 2015, there was a survey that I think almost 30,000 individuals completed. And what they found is that a large proportion of transgender individuals experience greater likelihood of experience polyvictimization So exposure to IPV, non-partnered violence in anti-transgender family and physical violence. So this is something that, in a sense, sets the forms of IPV that is experienced in our transgender and gender diverse individuals apart, is that there's anti-trans specific IPV that occurs, like withholding medication, not allowing people to go to doctor's appointments, things like that. And what they found in the survey was that nearly 1/4 or 24% had experienced severe physical violence by an intimate partner, which is higher than the general population. And up to 73% had reported being grabbed, punched, or choked. So again, those behaviors that confer high risk for brain injury. So we wanted to look at this, and we at Mount Sinai, we have the Center for Transgender Medicine and Surgery, and they have set up a research registry, and then anybody that has gone in for services can join the registry if they'd like. So we sent out a flyer and said, hey, we're wanting to look at partner violence and brain injury. Click the link if you're interested, right? That's all we did. And it was sent out to 600 people, and 76 came back and with responses, which is pretty high proportion, right? It wasn't recruitment, it was just, hey, click the link if you want to do this survey. And so a pretty high rate of response. And when we first looked at like just general exposure or general reporting of abuse and trauma, and what we found was that 56% reported emotional abuse, 35% reported physical abuse, and 30% reported sexual abuse. And then when we look at that cumulative trauma, we see that many individuals reported experiencing two or more types of violence. And for the violence in general, it was more so in our transgender women than our transgender men. Sorry, I just realized those are small. But the light purple is transgender women, the peachy color is transgender men, and then green is gender diverse. And so we see that, you know, more of our transgender women are reporting cumulative or multiple forms of exposure to abuse. So then what we did is we had given them, as part of the survey, was a modified IPV survey from the brain injury screening questionnaire. And we had them complete that. But before then, Kristen Downes-O'Connor had published a paper using a modified version of the brain injury screening questionnaire, where she added an IPV module, and had a group of individuals who, from the LETB study, who had reported IPV-related head trauma events. And so what we did is we looked at our sample and compared it to the outcomes that had been reported in that paper and what she had seen. And so for IPV head trauma events, this is if an individual said yes to a head trauma event, and then they didn't necessarily have to say yes to anything else with loss of consciousness or memory impairments. But what we see is that our transgender men are actually reporting more head trauma events. Everybody's reporting more than cisgender men. Then when we look at IPV-BI, so this is, they said yes to an injury, but then afterwards either yes to like loss of consciousness or alteration in memory, post-traumatic amnesia. Again, across the board, we're seeing higher IPV-related brain injury in our trans women, trans men, and cisgender women compared to cisgender men, as well as when we look at this, when we combine our IPV head trauma events or brain injury, we see again that we're seeing really high proportion of reported events and brain injury in our trans individuals. And in this one, our trans men were a little bit even higher than what we're seeing in cisgender women. So those numbers that we've been reporting in cisgender women were actually higher in our trans men. We don't know when the abuse occurred within the lifespan though, and so this is something that we are following up on. So to summarize, the scope of this problem is significant and really extremely understudied to date. And we are seeing that exposure to IPV impacts cognitive and psychological health, as well as brain structure and function. And these effects seem to be compounded in women who have experienced IPV-related head trauma, particularly those with current symptoms. And we know that no one is immune to IPV, but sexual and gender minorities or Indigenous individuals and those from underserved communities seem to be at heightened risk. And they also have less access to services or resources. So if you are interested in this and we're working with patients or individuals who have experienced IPV-related brain injury, we've started our Enigma working group has started the Global Knowledge Exchange Network. And what we're doing with the GCAN is we're trying to provide a safe space for care providers to share their experiences and knowledge of IPV brain injury, hoping to accelerate education, clinical care, research, and knowledge translation. And so how this works is every 2 months, we have a meeting every 2 months, and we have a fireside chat where clinicians, the care providers, stakeholders come together, and we just give them the space to chat about a specific topic within the area. They are able to sort of learn from each other, feed from each other on how the things they're finding are working in what they're doing, the things they've been having troubles with. And then what we do is we try to highlight some of the biggest gaps or issues that our care providers and our stakeholders are telling us about. And then we come back 2 months later and provide an education session with the lead or the expert in that area and have them give an education session to provide the support to the care providers. And this has been going very well. We've been very excited about it. And end of November, we will have an education session on IPV strangulation injuries, led by Michelle Patch and Jacqueline Campbell. So that'll be very good. If you guys are interested, that's how you can join, is the email below. Next week, Enigma IPV Working Group, in collaboration with Pink Concussions, is hosting a free virtual IPV brain injury conference, the mission being in the science and on the ground. So we're splitting this to have a half conference for care providers, half on research, but we're mixing it all together so that we're reducing those silos and bringing everybody together to hopefully learn a lot. So if you're interested, registration is free, conference is free, it will be recorded, and it will be hosted on the IPV website afterwards. But you can hit that QR code and it'll take you to the registration. So with that, I'd like to acknowledge all the collaborators and everybody that's made this work possible, and thank you all for your time.
Thanks very much, Dr. Esopenko. Wonderful, enlightening, motivating, and much appreciated. Thank you for sharing your science with us. I open up to questions. Would anyone in the audience like to start?
So I don't.
Oh, and could I ask you to use the microphone and introduce yourself first?
Hi, Eliana from the Concussion Center. I just had a question, kind of going back to earlier in your talk where you were talking about like PTSD and TBI, and looking at kind of who had psychological symptoms versus cognitive symptoms versus both, whatever. And I guess obviously I think there's so much science needing to be done about like what percentage of people are still experiencing problems and the nature of the problems. Mm-hmm. But I was curious whether you did any work looking at the people who were like doing well despite kind of all the cards being stacked against them. And if those people might have any like differences in obviously a whole ton of factors, I'm sure. But I was just curious.
Not yet, but yes, I want to. Like, I always feel like everything's a bimodal distribution. And so, yeah, I think we always focus on the negative and like who's not doing, but I think part of it, and I think we do this a lot with like the concussion world, is figure out why people are doing well. to sort of flip that narrative. And yeah, I'm hoping we will be able to do that with a larger sample.
Bretson?
Hello, and thank you for sharing this really important work. It really means a lot, probably to a lot of people in the audience. And so I'm wondering if you shared a lot of negative things coming from your work, but could you provide any aspects of hope from what you're doing to help in this community?
Oh, wow. I don't want it to all come off negative. That's why I try to end with it, like
No, it was
educating our
really
care
good.
providers and. No, I think, I think the focus that has shifted and the amount of people we now have talking about it, the fact that you brought like me out to the Concussion Center to talk about this, I think that's what gives me the biggest hope, is that we're changing the narrative and people are talking about it, people are aware of it. And, we've been seeing, and I could have added, I have extra time. I didn't think I would. I took some slides out because I thought I was gonna go way over, but talk too quickly apparently. But even with our care provider stuff, we're seeing people be able to now ask the question and screen for IPV brain injury. And even in our large epi studies, getting people to think about asking those questions and adding it as a mechanism that's happening so that we can get better epi understanding of the problem to then sort of identify better resources or more resources, because it's an under-resourced area for our providers, especially coming out of COVID. Everybody is extremely burnt out, and COVID really led to an influx, or, it was referred to as the shadow pandemic during COVID, was the amount of, or the higher amounts of intimate partner violence, because in a sense, we were having people stay at home with their abuser. And so all of our care providers and our stakeholders, like who are running, all these outreach centers, are so overworked right now and are so becoming burnt out because there's just a huge need. And hopefully us sitting here talking about it helps them get more resources and helps us be able to resource our community better so that they can provide the services that are drastically needed. And so that's a positive. We're identifying that these issues are here and we're saying that it's a problem. We need to do something about it, but people are now really starting to listen. And like, even the first round of, when I first submitted a grant on this, it was like, just go back to athletes. And I'm like, but it's very different. Like, you don't understand. And then now it's like to the other end where everybody's like, this is such a problem. And it's great to see that narrative change. That makes sense.
Go ahead, Reed.
Thanks so much, Carrie, for that. So I think in one of your early slides, you mentioned, or you showed that I think 1 in 3 female military members reported MST. Do you think there's or this might be anecdotal, but do you think there's a problem with non-reporting of this? I know in sport, there's studies that look at people willingly don't report. I just wanted your thoughts on that.
Yeah, I think, so just like another sort of difference between MST, if you talk to Jillian Menifee, who's a person that I've learned an immense amount from in my work, she would say the big difference between them is that IPV tends to be over time, tends to keep happening. MST, for the most part, could be like a single thing, or it only happens during the military service, right? But it comes with such different baggage. Like this whole idea of institutional betrayal is very big because the person has volunteered to give their service to their country, to protect the country, to do this very important mission that they feel very, like forced within themselves to do it. And then this happens and they can't report it because then what will happen? Where's it going to go? So yeah, I do think there's a lot of underreporting and a lot of baggage from that other big psychological side of this.
Carrie, there's a question from a participant online. Of course, here you did study MST, PTSD, and intimate partner violence. This is an audience member who's interested in knowing the extent to which what you're seeing here. I think concussion, in particular in TBI, differs from the youth population, and they're interested mostly in middle and high school students?
That is a really good question, and I honestly don't know what like from a dating violence perspective, I think it's 1 in 12 high school students in the US experience sexual or physical dating violence. I don't really know what that looks like. I'll be completely honest. I haven't done any work under age of 18, mostly because getting IRB ability to do 18 plus is really hard. So we haven't done it, but I do, like, for instance, my postdoctoral fellow, Divya Jain, who is, did all the trans work and will be on the job market next year, just saying. That's like one of her interests. So I think she'll hopefully be able to answer that question for us in a few years.
Carrie, another from a participant online is very positive. As a 35-year-old severe brain injury survivor, thank you for the work you're doing, 2 exclamation marks. There's a huge difference in the information available now, and it's nice to finally see a focus on women and female service members. Thank you.
That's actually what gives me the most hope, is that getting that feedback from people and hearing that it's having a really big impact. I think actually, Abby, if I could re-answer your question. So thank you to whoever added that to the chat. I really do appreciate that.
Just comment question. So obviously the numbers are kind of staggering, and obviously it's just sad to see, especially in the military service. What's the military doing? I mean, are they doing something about this?
Yeah, I mean, I do think so. If you go, there's actually a lot online now from the military and the DoD. So I will fully admit that I'm Canadian and I still screw up VA versus DoD all the time. I am trying really hard if you're listening from the funding agencies. I promise. But yeah, they are offering, like if you go on, every VISN has like an MST agent and coordinator now. So they are offering services, and there is now reports that are coming out from DoD showing the data on it. So they are, actively stating about what's happening. I honestly don't know the actual outreach part of it. I'm not not because it's not happening, just because I'm not actually aware exactly what's happening. I'm aware of what specific programs are doing. For instance, Deline at the Houston VA and Catherine Iverson in Boston, they're doing a lot of work with IPV and interpersonal trauma with their veterans. So.
Gary, and so much of the work people do in public health, it's a very long road between the level, and timing of research that you're doing, and having results that have preventive effects. Already we see you raising awareness in those who are empowered and work with individuals who may be affected, which is, of course, a key part of prevention, related to primary prevention, get treatment as soon as it happens and detect it, long-term care, PTSD, and ideally we're upstream with primary prevention. Where do you see some of the shortest pathways in working on prevention? And do you specifically try to conduct your research to find preventive opportunities? Or are we really at the point, you said this multiple times, we're just trying to establish the epidemiology of this? How common is it, and among whom, and what context?
There's so many parts of that.
Yeah, that's one question.
So yeah, the epi is very much needed, and for Jillian Baker, this is for you. The epi is very much needed. Because I think we do need to, we know that it's a big problem. We need to figure out how. With regards to prevention, that's like answering how to get rid of gender-based violence. I don't know. I honestly don't know how to fix it. I think through education, that kind of thing, we are, in a sense, coming on the other side of this of it's happening. How do we make it better for the person it's happened to, right? So through that, you know, like the SOAR program in Canada is doing a really great job with educating and providing services for care providers, like you do trainings to be able to screen for IPV brain injury. And you know, people like Mike Ellis in Winnipeg are putting together physician resources and you know, publishing living resources for physician, by publishing, I mean, putting on the web, on a website so everybody can access it. But providing this resource to physicians so that when a person does come in for care, they know what to do and they know how to help that person. Because when a person comes in, it's like in the acute moment, there's a lot happening, right? There's a lot of injury. There could be kids in the situation. There's legal stuff happening. It's like, what do you triage first, right? Do you worry about, say, the like fractured orbit and getting a person in for, you know, head CT, or do you screen for brain injury? Like, which one is gonna come first? It's gonna be dealing with that acute situation, or it's gonna be dealing with what's happening with the kid situation and right in that moment. So I think we're coming at that side of like trying to provide the education and support for the people that are on the front line.
Thank you so much. And it's, you know, so impressive that you're asking these hard questions, pursuing them with rigorous research, and pursuing federal funding successfully to do it. So good for you, and thank you for trailblazing, Dr. Esopenko. Appreciate your talk on understanding the intersection between brain injury and PTSD. Also like to thank everyone for joining us today. A reminder, our next talk in the speaker seminar series will be Thursday, November 16th at 4 p.m. The title will be Concussion and CTE Litigation, 2023 Update and Beyond. And that will be conducted by lawyers from Montgomery, McCracken, Walker, and Rhodes. So we look forward to seeing you then. And thank you again for joining us today. Bye-bye.